Okay, it is 1. So you can go ahead on Blackboard, go to quizzes. It should be available. And go ahead and take the quiz. Once everybody's done, we will go ahead and talk about psychiatric disorders. Yes, quiz 5, last quiz. All right, so everyone on Zoom as well, go to Blackboard, quiz 5. Finish, and we'll go ahead and get started. So for those of you who may have signed on a little late on Zoom, we have quiz 5. So feel free to take it while I talk if you want. Let me get our friend the projector. Hopefully the wake up. Code and share screen. Alrighty, so today we are talking about psychiatric disorders. Part of that is how we have treated psychiatric disorders, both now and in the past. And then part of that is just talking about what we know about how they differ in the brain, with the caveat that this is one of the areas where our, oh, I have to figure out what to do. There we go. With the caveat that this is one of the areas where our research is the most inconsistent. For a couple of reasons. One, we often have small sample sizes. Some of these disorders, it can be difficult to find a lot of people with the disorder. Others, it's just brain scan studies are pricey, right? So if you're someone who studies eating disorders like me, or studies depression, anxiety, and you're not like in the grant pipeline to get all the money to pay for that fMRI time, it can be really difficult to get big grants to do this. And so even if you get grants, you might have samples of like 20 people. As my scientific literacy class has been talking about this semester, when you have samples that small, you just get weird data, because if one person is an anomaly, it can throw off your small data set, right? So What's really important to look at here is meta-analyses, where they kind of look at all these different brain scan studies together. And then also to just sort of continue to look at this over time. So we know the brain is the start of behavior. When I was in undergrad, we sort of separated our psych major into 2 tracks. You had to take X amount of classes in each track. And one was behavior and context. That's where things like social psych, clinical, and normal would all end up. And then the other side was something brain. Oh, that's real specific and helpful. But you know, it basically kind of talked about those as 2 different tracks of looking at psychology, although fully acknowledging those aren't mutually exclusive, right? That the brain does control behavior. And psychiatric or behavioral disorders have a biological, anatomical, and or genetic basis. Now, we know that that doesn't mean the environment has no effect, right? If you get really stressed out, that can make symptoms of a disorder you have a vulnerability for come out, right? So one of the things we've touched on in here a little bit is the HPA axis, the hypothalamic pituitary adrenal axis. This is really implicated in stress. And so people with anxiety disorders, for example, often have an overactive HPA axis. And so what we're going to do is take a few minutes to talk about just a couple of these disorders and what we do know about the brain. And then we're going to spend a lot of today talking about the ways we've treated these in both good and bad ways. In particular, I have some videos to show about lobotomies, which is one of the ways they used to treat disorders. If you don't know what that is, they'd essentially mutilate your prefrontal cortex. And as we've learned this semester, that's where things like planning and organizing and your personality and your emotions are, right? And so you'd be super docile, right? But you've now like taken away that person's personality. Oh, real quick, I just got this dress and it is a neuron Mandela dress. It's all made of neurons. So I thought you all would appreciate that. Yeah, it's really fun. I just find myself like staring at it when I'm up close to it because they're all kind of a little bit different. But yes, I think that a lot of times we do get into these sort of 2 lines of like, well, there's bio-y psych and there's socially psych, right? There's like sort of the biology psych and the sociology psych, but obviously they intersect and overlap. Yeah.
And if you want to look at from the pop culture standpoint, there's a movie and it's called Sucker Punch.
I've heard of it. I've never seen it.
And like, spoilers, but like there's a lobotomy in the movie, and it kind of talks about like what that does to her. What that does to her.
Interesting. Okay, I'll have to look into it. That might be great for my psych and film course at some point. Which, if you're interested in that, I will next offer that next January. So January 2023. Yeah, it's a fun class, especially now that I've diversified it. It's even better. So. All right, so we're going to start by talking about schizophrenia, mostly because I think if you talk to a layperson about mental illness, the first thing they tend to think of is schizophrenia, right? That's what we see in the movies. Oh, you know, like people who talk to themselves, you know, things along those lines is what comes out first. So these folks have delusions, which are fixed, false beliefs about the world around them, and hallucinations, which are abnormal sensory experiences. So hallucinations can be in any of our senses. We tend to think of them as visual and particularly auditory in schizophrenia. Oh, you're hearing voices. But you can like see things that aren't there. They can interact, or you like see and hear a person that's not there. You can also smell, taste, feel things that aren't there. So like little ants crawling on you, things like that. Other symptoms people don't know as much about with schizophrenia include disorganization. And so this is disorganized speech and disorganized thought and disorganized behavior. So there's a whole gamut of the speech from being like a little not just a little, but being so tangential it can be like hard to follow, to echolalia, which is where you just repeat what people say to you. Or just some of them are completely mute. Not because of anything physically wrong, just, you know, they're in their own world essentially. Disorganized behavior can range from echopraxia, which is repeating what people say, disorganized, or what people do, sorry. Or it can be like depression, honestly, where they're just not engaging in basic self-care. Or the most extreme version of disorganized behavior is what's called catatonia, where they may just sit and do nothing. And sometimes that comes with what's called a waxy flexibility. And the best way to describe this is a very dated reference. So forgive me if you don't get this. There used to be this little green guy called Gummy. And his whims were kind of like you could just kind of mold them whatever way. Okay, kind of like a Stretch Armstrong or something like that. And so they'll like hold these weird poses sometimes. And if you are like worried about them in that, you can just kind of remold their arm and they won't react. That's very extreme and pretty rare. Typically, we're going to be seeing the disorganization and delusions and or hallucinations. So in terms of what's going on in the brains of people with schizophrenia, we tend to see that they are less than average weight for a brain, so smaller volume. Part of that is due to the fact that the ventricles, those fluid-filled spaces, if you remember that kind of like kidneys, those are larger. There seem to be fewer neurons and perhaps relatedly fewer connections between neurons in the prefrontal cortex. Abnormal cellular structure there as well as in the hippocampus. And if you remember, the hippocampus has to do with memory. So you could certainly see how like remembering these abnormal experiences could end up with that continuing and sort of self-perpetuating any kind of delusions or hallucinations. They are, again, probably because of these issues in the frontal cortex, if you gave them Wisconsin hard sort, the one where you change directions continually, they tend to have a really hard time changing directions, right? So they'll just keep doing whatever pattern they originally did, despite any feedback you get. We know that dopamine is off in schizophrenia, and that it in particular seems to interact with a lot of the other neurotransmitters as well. And so antipsychotics, or at least most antipsychotic medications, specifically act on the dopamine functionality in the brain. If you were to give someone with schizophrenia a neuropsychological assessment, they do very poorly, as I already mentioned, on frontal lobe-based tasks. So not only hard sort, but things like trails and the Stroop. And they have poor performance on verbal and nonverbal memory. And they honestly just might not perform well on any test you give them. And there's a reason for that, particularly if they're actively hallucinating. So this is a great video that CNN did where they had Anderson Cooper wear headphones to see what it's like as a person with schizophrenia who has active auditory hallucinations, to live your life like that. Those of you who aren't familiar with Anderson Cooper, he is a fairly smart individual, pretty well-respected journalist, and you'll see his struggles with some of these things.
So I'm going to put these earphones in and they're going to try to do a series.
It's not going to work if we can't hear it because it's all about the voices. So let me figure out what's muted where here. Okay, that's supposed to be up.
Of tests.
I swear to God. Guys, sometimes I feel like my high school history teacher who couldn't work the slide projector, but I hope you all know that I really do have some competency with technology. That is true. I'm sure there are people who don't know how to do that. No, they're not buzzing, so I'm wondering if someone just like turned them off. You know what? Let me try something. It might not be great, but I might be able to just have it try different speakers.
Okay, so I'm now hearing
Yeah,
some whispers and
So
voices
it's not
in my
going to be
head.
great
And
sound because it's through the computer, but at least there's some sound. So I'm going to crank it in all the places I can crank it here. Let me just make sure. Yeah. Honestly, the people on Zoom will probably be able to hear it better than everybody else. I'll turn on the captions too, so you get a vibe.
the first test is on some number puzzles.
So what they're doing is while he's listening to the voices, they're making him do basically like neuropsych tests. So really more like the screening, like the MMS, things like that. Pretty simple things.
You suck and they know it. Can't you get this right?
Okay, so I did this test for 3 minutes and I did not get a single one. It's very hard to concentrate if it's like music or something constant, it's easy, but people talking to you is very difficult. So now I'm going to be asked a series of questions by our producer, Susan, and these are basically a series of questions that a person would be asked if they were being admitted to a hospital.
Can you tell me what day it is?
Yeah, it's Sunday, June, I don't know, what's the date, 7th?
So I'm going to say 5 numbers, and I want you to repeat them back to me after I'm done.
Okay.
5, 23, 67, 2, 76.
5, 23, 67, something 76.
I'm going to say 5 words. You don't have to repeat them, but just listen to them. Cat, book, cigar, damage, and rain.
Make you okay.
Can you name the last 4 presidents of the United States?
Okay for you to be
Barack
here.
Obama, George
And
Bush,
Here. Here. Right here.
Bill Clinton, and George Bush.
Hear it? Hear
So
it
those
now?
5 words I said
And
before.
like, this is his job, right? Normally he could just rattle this off that fast. Like he covers a lot of politics.
Can you remember any of
Here
them?
and here. Hear it.
No. It's hard because sometimes voices are like whispering, and sometimes they're aggressive, and sometimes they're kind of comforting. And
Hear the tree.
but again, with people kind of talking to you all the time,
It's okay.
it's hard.
Don't worry. Now or later.
So I'm
Don't
gonna try to
worry.
make a boat
You all right?
origami following these instructions.
Hey, it'll be okay.
I'm going to skip ahead because they actually have him like
Okay. I'll just,
log up and try to do stuff he does every day, like go to a newsstand, buy a newspaper, that type of thing.
hey, do you have yesterday's paper? Yesterday's New York Times? No? Okay. I'll just get today's. It's incredibly distracting on the street to have somebody talking in your head, and it makes you feel completely isolated from everyone else around you, and you don't want to engage in conversation with other people. You kind of find yourself wanting to engage in conversation with a voice in your head because they're constantly being really negative and talking to you, and everything they're saying relates to things that you're actually doing. They're criticizing things you're doing. It's like it's like you have a chorus watching you and commenting on what you're doing, and you can't help it. I mean, I literally find myself wanting to kind of respond to them, kind of tell them to be quiet, and it's incredibly unpleasant. This is a very, very unpleasant experiment. It's really, I mean, it's eye-opening because it kind of really shows you what other people must be going through who deal with this on a regular basis. But also, like, I cannot wait to take these headphones off because it's really depressing. It's very negative. It makes you feel very, very negative. Yeah.
So again, he did this for I think like half hour, an hour, right? And he was already like about to start talking back to the voices. So imagine if that was like always your life. Of course, we see people who are on the street walking around talking to themselves because they have this constant dialogue, right? And part of what happened with this, just to give you like a little socio-historical context, is prior to the 70s, we had state-funded hospitals where these folks would often be for the rest of their lives. They weren't great, let's be honest, and often the conditions were abysmal. So I don't think that we should have left them as is, but rather than try to fix them, the solution was what they called deinstitutionalization, or they just shut most of them down. And so people who probably should have been in some sort of facility where they had adequate care the rest of their lives were now released. And everyone was like, yeah, they're free. But often without the support they needed. And so this is why we see a high rate of mental illness among the homeless. Now, this doesn't mean everyone who's homeless has a mental illness, but essentially the way our system works, if you can't hold down a job, which again, try to imagine doing that with all this in your head all the time, you end up on the streets. And so we do see this, again, unfortunately, because in my opinion, we have failed these people and we are trying ways to quote unquote fix it and to do like integrated care. And I actually know people personally who are trying to do this really well, but we still have to figure out places to like give these people to live and help them have the financial resources to sustain. And with people with schizophrenia and bipolar disorder, which we'll talk about in a minute, like their disorder essentially tells them they don't need this help, right? In schizophrenia, it may actually be the voices they're hearing, and bipolar disorder, when they're manic, they're like, oh, I can take medication, I'm great, right? So that you're always sort of fighting against that. All right, so talking about depression here and bipolar disorder. So these are both considered mood disorders. And basically you have different types of mood episodes. I'm not going to go into my full abnormal or about adult psychopathology, which I love, lecture. But essentially there are depressive mood episodes and manic mood episodes. Depressive mood episodes are what we think of when we think of depression. People feel depressed or down most of the day, nearly every day. They stop enjoying things they usually enjoy. They may have changes in appetite, changes in sleep. They may move much more slowly than usual, feel a loss of energy. This can get to the point of what's sometimes called leaden paralysis, where it's just they're so weighed down by this disorder that it feels like their limbs are like covered in cement and it's really hard for them to do even basic tasks. They have feelings of worthlessness or inappropriate guilt. Everything is their fault. Why would anyone want to be around them? They have troubles thinking or concentrating. And obviously the most critical symptom we want to be aware of is suicidal ideation, thinking about death or in particular planning for their own death. Mania or manic episodes are the opposite. So you feel really, really good. And it can be just expansive or high feeling, but it also can be really irritable. But you have grandiose self-esteem. You feel like I'm the best person in the world. Nothing can hurt me. You feel like you don't need to sleep as much. You talk much more quickly than usual, partially because your thoughts are going much more quickly than usual. You're easily distracted, kind of jump from thing to thing. You increase your activity, and you can see this motorly as well, like sort of bouncing limbs, that type of thing. And then you engage in high-risk activities because you believe nothing can harm you. So this can be something like, I had a friend who was bipolar in college, and she would like go spend all her money on eBay when she was in a manic episode. It's like, as a college student, you don't have much money to begin with, right? But it can get more extreme, more dangerous, drinking and driving, engaging in unprotected sex with a lot of different people, things along those lines.
When they have medical disorders, they give their credit card to their girlfriend and
Smart.
they try their best to sleep because they don't need it.
Smart. Yeah, that's really, really smart. Yeah. I mean, when they're in a manic episode, they just feel so good that, like, I've never had someone this extreme, but other therapists I know just like they stop coming to therapy for like a month and you don't know what's happening with your client because they're like, I don't need therapy, I don't need their medication. And so sometimes they'll end up inpatient hospitalized just because they are a risk to themselves, not in terms of like physically harming themselves, but maybe coming to harm because of these activities they're engaging in. So if you only have depressive episodes, you would be diagnosed with depressive disorder or major depression. If you have both depressive and manic episodes, then you'd be diagnosed as bipolar. All right, so in depression, we know a lot about this. Depression is the most common mental illness. It's about 12% of people will suffer from it. Many more women than men, so about 25% of women will experience a depressive episode at some point in their life. So they also have issues in that HPA axis I talked about just a couple minutes ago for anxiety. They over-secrete cortisol. Cortisol is a hormone related to stress. So if you always have a lot of cortisol in your body's always in sort of this chronic state of stress, we know that's not good, right? And this can lead to things like that leaden paralysis. It kills granule cells in the hippocampus, and it just influences our overall cerebral functioning in general. Basically, a lot of our functioning is sort of downregulated because of this chronic stress. We know that serotonin is really implicated. So one of the largest classes and probably the most commonly used classes of antidepressants now is the SSRIs, which stands for selective serotonin reuptake inhibitors. The way I always describe this is, okay, so you've got, you can turn to these, but they're kind of tiny, right? So then you have the synapse between two neurons, right? So I'm going to blow it up like this. Okay, so you've got one neuron sending the message over, and then you've got the other neuron accepting it. And then, like, it sends a bunch of serotonin over, and there's some extra. So this sending neuron has like almost like a vacuum feature where it doesn't want to waste the serotonin, so it sucks it back up for the next one. In people who are depressed, that seems to be overactive. And so you don't get the chance to get all that nice serotonin flowing through your synapse. So selective serotonin reuptake inhibitors essentially clog the vacuum. You have pets, if you've ever had your vacuum clog up with pet hair, okay, it's essentially that. So that the serotonin stays in the synapse longer and you get the benefits of it. We see reduced memory and attention, decreased activity in the dorsolateral and medial prefrontal regions. We see more activity in the orbital regions, which are an attempt to inhibit all this extra activity in the amygdala linked to stress and to break those persistent negative thoughts. The sleep cycle may be altered because of the serotonin. So some people with depression will sleep more than usual. I knew someone who really thought they had mono. They were in college, mono was still a really big thing back then. Got tested, didn't have it, and their doctor was like, could you be depressed? And they were like, what? But that's what it was. So they would like sleep all day, get up, still be tired. It can look like mono, but it's actually depression. And the thyroid hormones can actually, this is actually something, if you have a patient who comes in for therapy with depression and their family has a history of thyroid issues, you should get them tested because sometimes just thyroid issues look like depression. So sometimes you can fix depression in those particular people just by getting them on thyroid medication. So it's always good to get a medical workup.
My mom recently had a CPD flare-up, and they are going to do a test for her for sleep apnea. And I a lot of her depression symptoms are starting to lighten now that she's able to like breathe.
Oh, that's awesome. That's great. Yeah, sleep apnea is something else that like a lot of people suffer from. That makes a huge difference. If you're not familiar with sleep apnea, essentially you stop breathing for like little periods of time, which seems like, whatever. But those build up because every time you stop breathing, you stop the flow of oxygen into the brain, right? So it can actually lead to memory problems, feelings like depression, things along those lines. So in terms of bipolar disorder, we see decreased gray matter, particularly in the temporal lobe and the cerebellum. And the decrease is related to how many mood episodes you've had lifetime. So it's like every time you have this swing, it seems to affect it. Now, one thing I always like to say about bipolar disorder is, again, the movies aren't exactly accurate here. They show people just like flipping back and forth between manic and depressed. But like, in order to meet criteria for a depressive episode, you have to have symptoms for 2 weeks. In order to meet the criteria for a full manic episode, you have to have symptoms for 7 days or be severe enough to need to be hospitalized. So rapid cycling bipolar disorder is typically like several episodes over the course of a year, right? So we're not going to see people just bounce back and forth. There's an idea that maybe bipolar patients are more sensitive to stress and to medications or street drugs. And we're seeing that these episodes of mood disorder do change the brain. And so they might already be more sensitive to stress. And then they're also having these mood changes, right? We know there's a link between certain stimulant medications and mania, maybe not surprisingly. And one of the things that seems to be most common for people with bipolar disorder is that one of their high-risk behaviors they engage in is drug use. And so again, this might be linked to that sensitivity, getting sort of more charge out of it. So really interestingly, we would think that, okay, so if you have low serotonin when you're depressed, so when you're manic, you must have high serotonin. But in fact, it seems like it's still under activity of your serotonin, but it's also high levels of norepinephrine, which is another neurotransmitter. So essentially, if your norepinephrine's low and your serotonin's low, depressive episode. If your serotonin's low and your norepinephrine is high, manic episode. So there does seem to be this common thread. We do see some differences in the basal ganglia seem to be slightly smaller, some other structural abnormalities as well. I think I'm going to pause there before I go on to the anxiety disorders and show a quick video here of what it's like to live with bipolar disorder. Because again, I think it's most helpful
there is still a stigma
to see. What's that? Sure.
Hypomania.
Mm-hmm.
Very different than normal mania.
Right. Yeah. I was kind of skipping.
I think
Yeah.
hypomania is at least 3 days.
Yep.
And it's basically the same thing, but it's not as great. It's talking, can't sleep. I have bipolar, so I know my manic episodes, I don't sleep. Find that really just like happening where I'm clean, I do all kinds of stuff. And in the past, I have done. But basically, yes. In my past, I've done a lot of things that were
Sure.
but hypomania is very real.
Yes, and so that's something that's really great that I was skimming over that Debbie's pointing out. So in addition to full manic episodes, you can have sort of a lower grade, shorter one called hypomania. And if you've ever heard of the fact that we have bipolar 1 and bipolar 2 disorder, bipolar 2 are people who tend to have those hypomanic episodes instead of the full manic episodes. So if you are someone who has the full manic episodes, then you're diagnosed with bipolar 1.
So I remember reading a little while ago that hypomanic episodes in bipolar 1 and 2 big part of the reason people often confuse bipolar disorder with borderline personality.
Oh, I can see that. Yeah.
So a lot of times when people, and that's actually what I'm doing for my project for science.
Nice.
About bipolar just being mood swings, when in reality that's actually most commonly associated with borderline.
That's okay. We probably have a lot of overlaps for that class. Yeah, yeah. So if you're not familiar with the personality disorders, borderline personality disorder is a disorder often linked to trauma, often comorbid with bipolar disorder, but some symptoms that kind of look similar at times. But yeah, for bipolar disorder, you actually do need to have these changes in mood. So that's a really good point as well. And it can be hard as a clinician to parse these things out sometimes, honestly. Even something like depression and anxiety can be hard to parse out, especially if they start at the same time. So there's an anxiety disorder called generalized anxiety disorder, where you just kind of worry about everything all the time. And it's not a just, like it's, I have high functioning GAD, and when it is not high functioning, it is like paralyzing. And if you develop symptoms of that and major depressive disorder at the same time, you actually have to pick one to diagnose because the symptoms are so similar. You basically go with which one seems more overwhelming to the person.
Well, and it's also kind of, I don't want to say scary, but like concerning as a patient. And I remember before I got my diagnosis, I was going through the test and I was just like, this test is so easy to read.
Oh yeah.
So a lot of the questions, the way they're worded, you know exactly what they're looking for, the answers that you're giving. So it's like, do I want to be honest? If I'm honest, am I going to get a certain diagnosis? If I'm not honest, am I going to get hospitalized? Like there is so much confusion there that it's not fun.
Yeah, yeah. I think that's it. What Will just brought up is a really good point. So, you know, we can't just do a neuropsych test, right, to get at some of these things. Like you have to actually ask people how they're feeling and what they're thinking. And that's much more subjective. So particularly if you're someone who has schizophrenia, in the throes of depression, in a manic episode, you can lack insight into your own behaviors. Or if you have insight, it's easy to manipulate these things. Yeah, I can. So I think I've shared with you all before that I had postpartum depression and anxiety, and the scale they give you for that's called the Glasgow scale. And it's so obvious what they're trying to pull for. And so a lot of women in the support group I used to go to said that they used to lie because they thought that like if they reported the symptoms they were experiencing, like Child Protective Services would try to take kids away. It's not actually true. We have a lot of resources now. We don't need to do that. But it's certainly a fear, especially if you have postpartum anxiety, you're nervous about everything anyway, that can play into things. So yeah, in my assessment class, we've been talking about how longer comprehensive inventories, like the MMPI, for example, or the PII, have validity scales built into them so that you can try to catch if someone is sort of like faking bad or even faking good, right? So, but if you're just giving those shorter questionnaires, that's not in there. So yeah, it's certainly a problem, right? And that's why, you know, again, if you're doing a neuropsych part of it, you want to throw something like the TOM in, right? And try to have something. Sometimes what we'll do is just give people a measure of what's called social desirability. There's a, I think it's called the Marla Crown Social Desirability Scale. It's at the page front and back. And it can kind of tell you if that person is just saying what they think you want it to hear, basically, or the opposite, right? So yeah, really, really good points. Psychiatric diagnosis is very tricky, partially because, again, we don't have a magical scanner that we can just be like, boop, you have depression. Partially because people can lack insight, and partially because people can have insight, but not want to be honest with you as a therapist for a whole host of reasons, right? Don't believe they need therapy, think it will somehow harm their kids if, or their relationship with their kids if they admit to it, things along those lines. So this can be pretty tricky. And it's not unusual for someone to come to you with a stroke, dementia, other memory problems, traumatic brain injury, and also have a psychiatric disorder, right? Like traumatic brain injury, it's really common to also have PTSD, for example, or, you know, people who have dementia or cancer or a stroke might have symptoms of depression because of the changes they've experienced. And we've heard of some of that in our case studies. Yeah.
I mean, I was just talking about really just like talking about, people can manipulate things and worries about, I mean, it's so disproportionate to race as well. Like
yeah.
African Americans who get their kids taken away because of something simple that was the woman in Florida recently. Her kids were taken away. I can't remember the story off the top of my head, but like it happens, and so it's a lot harder to get help. It's a lot harder to ask resources that are open to other people because of understand.
That's such a good point, Debbie. And we have a history as the field of psychology of treating people of color horribly. So I don't blame people of color for not wanting to seek psychological care, to be perfectly honest. The APA, and again, those of you in my scientific literacy class are like, I'm preaching to the choir, you already know this, but the APA actually just came out with a formal apology for all of the race-based discrimination and horrible things. Like there were psychologists who were eugenicists. I mean, like horrible, horrible things. Now, I don't know how much good that apology is going to do other than an acknowledgement and hopefully leading to some policy changes, et cetera. But at least there's some acknowledgement, right? I told my class, like, it makes me think of my daughter watches Daniel Tiger, and there's a little song that's like, saying I'm sorry is the first step. Then how can I help? Right? We need that how can I help component. Yeah. So, and also class comes into that as well, right? So people who are impoverished are much more likely to have their kids taken away. That's going to interact with race and gender as well. So yeah, that's a really, really good point. All right, so a little bit of a clip about living with bipolar disorder, and then I'm going to show the clip about lobotomies.
Stigma about mental illness. It is something that many of us are still uncomfortable talking about. But the fact of the matter is, it is more common than you think. There are millions of people who are living with and are struggling with some form of mental health issue every day. As we continue our look at mental health leading up to this summer's Courtnall Classic fundraiser, A News reporter Louise Hartland introduces us tonight to a woman who is living with bipolar disorder.
Christine McKinnon is putting the finishing touches on a work of art. But for the 45-year-old, this is also a form of therapy.
Kind of a chameleon of a disease because it presents quite differently in different people. And even from episode to episode, from mood to mood, you can get quite a bit of difference.
12 years ago, after witnessing Christine go through a series of severe highs and lows, a friend told her it was time to get some help. Days later, Christine was diagnosed bipolar. Bipolar or manic depressive illness is a medical condition giving people extreme mood swings.
Yeah, so manic depressive disorder is the old name for bipolar disorder. It's a little more descriptive, but some of the stigma associated with it is the reason why they changed the name.
It affects more than 2% of the world's population, changing the way they think, behave, and function.
It was a relief for me when I found out that I had a name to what was wrong with me.
Christine was very depressed, at times thinking about suicide and hallucinating.
People often think the highs are exuberant and fun and high, and they actually can get quite debilitating.
For Christine, help came in the form of people such as Daphne Dobko-Walsh.
We try and teach them how to be independent and deal with their own illness.
As a community psychiatric nurse, Daphne visits people suffering with mood disorders. She assesses their health needs and develops plans to help them manage and recover.
The importance of having programs for people who are sick like this is no different than any other treatment that you would have for cancer or for diabetes. The more educated and aware that people are of what is happening to them, the better the outcome.
That's why she feels erasing the stigma around mental illness is a crucial step in helping people come forward.
Willingness is huge in having insight to know that there's a disease happening there, and also to have resources, to have the ability to connect with psychiatrists and or GPs and case managers or other community resources.
She's kind of talking about the same type of thing I was talking about with schizophrenia, right? Having a network of people that can help you. So releases of information between your therapist, your psychiatrist, any social worker you're working with, etc., your primary care doc, right, can all help you interact with this. All right, so gonna kind of warn you, there is some graphic description in this, so you know, if you're squeamish, heads up. So this is a piece of a documentary about lobotomy, and then I have another piece as well that we can watch, but this gets us started with what the surgery was, how it was done, that type of thing.
He was an idealistic doctor, hungry for fame, who would champion one of the century's most infamous medical procedures.
He wanted to solve the problems of psychiatry, and he wanted to do it fast.
The lesson here is not how a man can go off the rails, but is how science can go off the rails.
Ellen Ionesco was the first patient to undergo a procedure Dr. Freeman had perfected only weeks before. He called it transorbital lobotomy.
In a transorbital lobotomy, Freeman would first have the patient rendered unconscious through the use of the electroconvulsive shock machine.
Just before he threw the switch, we all had a laying on of hands and we went for a little ride.
Usually 3 successive convulsions are necessary, but in old people a single one may be sufficient, while in a sturdy young person 4 or even 6 convulsions may be administered without danger.
The patient would then enter unconsciousness for a relatively brief period, but several minutes.
Now that the convulsion has subsided, the nurse holds a towel over the nose and mouth of the patient.
Freeman would peel back each eyelid, insert his ice pick, and with a hammer, tap through the brain, wiggle it about, sever the frontal lobes, withdraw it. And when the patient came to, he or she would be given dark glasses to hide the black eyes they'd been given.
We didn't have a refrigerator, we had an ice box. The first ice picks came right out of our kitchen drawer, and they worked like a charm.
Turning now to the operation itself, very little preparation is necessary for transorbital lobotomy.
The instrument was put in above the eyeball and in the plane of the nose. You could feel it hit the roof of the orbit, and then with a tap of a hammer you could knock it through. The whole thing would take 3 or 4 minutes.
This patient came to the hospital this morning after breakfast, and he will leave tomorrow afternoon.
There are reports which he proudly writes down in his diary about fellow professionals fainting as he proceeds in this, or vomiting.
Dr. Watts didn't say anything. He simply turned around and walked out.
Spurred on by Freeman, the number of lobotomies performed annually soared from 150 in 1945 to over 5,000 in 1949. Despite the known side effects, there seemed to be an endless supply of willing patients. Ultimately, the fate of lobotomy would be settled by a pill. In 1954, a new drug called Thorazine began to sweep through state mental hospitals.
Thorazine was initially marketed as a chemical lobotomy. I mean, this was seen as a selling point, that it produced results similar to lobotomy, but without, of course, all the risks of the surgery.
Freeman decided to move to Los Altos, California, to resurrect his career. Far from the reproachful Eastern medical establishment, he could try to bring lobotomy to new categories of patients.
If housewives found their early 1950s existence too depressing for words, why, Freeman had a solution that would get them through their day happy as little clams. If children were misbehaving, conditions we might now see being called hyperactivity disorder, why they might need a lobotomy.
In all, Freeman lobotomized 19 children under the age of 18, including a 4-year-old. By 1967, Dr. Freeman had personally performed more than 2,900 lobotomies. In February, at Herrick Memorial Hospital in Berkeley, he performed his last when a patient died of a brain hemorrhage. Freeman was stripped of his hospital privileges and soon retired from his medical practice.
Super rare.
There is more.
But yeah, reactions. I know, I can't, like my daughter is 3, and I can't imagine like in 6 months being like, oh, she's a little hyperactive. Yeah, I mean, they said that at the beginning that he just really wanted to be famous, right?
It kind of reminds me of every once in a while when we talk about what are some procedures we do nowadays that in the future might be seen as horrendous, like this, like you were saying, 4-year-olds getting this procedure done. You know, nowadays we've got people diagnosing 5- and 6-year-olds with ADHD and trying to get them on medication. That seems like in the future it could potentially be on the same level as something like that.
Yeah, I totally agree. I think that I used the Star Trek example with y'all before, right? The Star Trek episode 4 movie. They go to the past, it's like modern day, and they're walking through a hospital in Bones. The doctor sees someone on dialysis, and he's like, "That's barbaric," right? I'm sure there are procedures we do now that in 10, 50 years we're gonna go, I can't believe we did that to people, right?
Especially that, like, you know, we have ECTs like Team with Cousin, you know, TMS, and that's good, but we still don't know why it works.
Right, and we still do ECT. So if you're not familiar with ECT, it's electroconvulsive therapy. It was what they were using to get the people knocked out to do lobotomies. I don't know why they wouldn't just do a general anesthetic. Maybe you didn't want to hire an anesthesiologist. I don't know. But essentially, you put a current through the brain and it creates something like a seizure. Back in sort of this day when they did it, people would convulse and like dislocate shoulders and things along those lines. Nowadays, they give you like muscle relaxants. You're often restrained just so you don't harm yourself. But same type of thing, like granted a 7 TMS, we don't know why ECT works, and yet we still do it. And there are some potential side effects. One of the people I did a neuropsych assessment on when I was in grad school had ECT and had memory loss because of it. There's a whole musical about it, actually. It's called Next to Normal. So if you can, find anything about, find any clips on YouTube or something, definitely go watch it. It's an extreme version, it's dramatized for the stage, but it is a mother who has bipolar disorder, who when she has ECT, it loses like almost all her memory. So, again, that's unusual, but it can happen. And yet we're like, okay. And again, ECT is never our first line of treatment. It really tends to be, honestly, for most people, it tends to be medication. Because most people, when they are not feeling good for any way, shape, or form, they go to their primary care doc. Primary care docs are trained in medication giving, not therapy, right? And they might refer for therapy, but people might be like, I don't have time for that, right? And we know that the medications, particularly things like SSRIs, are effective with relatively low side effects. But we also know that if you combine medication with therapy, it's the most effective. And therapy in and of itself, I couldn't find a video about this, which kind of bummed me out. But there's a lot of research that's come out in the past 10 years or so that shows that therapy actually changes your brain, which is really cool. Particularly the manualized therapies like cognitive behavioral therapy. We're showing changes in the HPA axis, for example. So here's a whole host of studies where they're looking at things like obsessive compulsive disorder, major depressive disorder, specific phobias, panic disorder, bipolar disorder, things along those lines. I'm not sure what Yeah, that's PD. Yeah, that's PD. I feel like I'm doing an eye test right now. Like, is that a no or is that a D? And so you can see, you know, they've looked at these with different types of imaging methods, but also pay attention to the sample sizes, right? Some of them, like one study had 2 people, right? So again, we need to be cautious when making interpretations based off these, and doing something like a meta-analysis is important. A lot of these are using cognitive behavioral therapy. Some are using interpersonal therapy or just behavioral therapy. And we see that there are changes. So there are similar brain changes to medication with therapy, which is really cool. So increases in the metabolism in the hippocampus and the dorsal cingulate with one study, decreases in other areas, and similar to medication differences. And so I just think that that's really cool that we are seeing these changes based on just doing talk therapy, right? It's just, again, I'm never going to be against psychotherapy medication, right? I just think that we could help a lot more people if we added therapy to it, right? And in fact, the research shows that. And so it really speaks to the importance of making therapy accessible to people. And so the conference that I go to every year, next week, the following week, one of the two, I'll be attending some sessions like in between classes. One of the things that I noticed a lot of the presentations are about this year is how do we make therapy accessible? And I think the pandemic kind of sparked that for some people, like, oh, we can do teletherapy. Can we reach more people that way? Can we do group teletherapy, right? For years, people have been working on therapy acts to try to do this. You know, what are ways we can address depression, insomnia, anxiety with not only just like using your app to do the type of homework you would do written down in traditional therapy, but like I remember seeing a game where they like, it's just like a little simple game where you like got these gophers to go back in their holes, and like they showed that doing that for a certain amount of time actually reduced your anxiety because it like got you to stop worrying, thinking about everything, and it was relaxing. So I think that that is sort of the next really important step is, okay, we have these great therapies. How do we make it so people can get it? How do we make it so people can afford it, right? Like that's a huge piece of it as well. And actually, I feel like we got a good enough a description of, we don't need to watch more gross stuff every time I watch it. I'm like, oh my God, through the eye every time. Before I found these videos for this class, I actually had heard they went through the nose, and like even that felt weird, but not as weird. And like when I saw that, I was like, oh my God, like through the eye, okay. Another, I mentioned generalized anxiety disorder. Anxiety in general is, after depression, probably the most common disorder people experience. And again, often you experience more than one disorder, right? And so generalized anxiety disorder is like worrying about everything all the time, and it results in like feeling restless, being easily fatigued, trouble concentrating, irritability, muscle tension, sleep disturbance. And one of the things I didn't mention about depression, mania, schizophrenia is we know these all have genetic components as well. So that sort of ties into these brain abnormalities. And that is true for anxiety. We know that in the 50s, so when good old Dr. Freeman was lobotomizing women, they also came up with medications that kind of did the same thing. So they mentioned Thorazine. Other common ones were Valium and Xanax. Valium in particular was referred to as mother's little helper in the 50s and 60s, because you had all these educated housewives who may have gone to Smith College, these really high level places, and then they were expected to just settle down and raise their family when they wanted to be using their minds. Also, a lot of women were part of the workforce during World War II because they needed people. Well, most of the men were abroad fighting. And then when the men came back, they were like, it's your patriotic duty to just go back to the home. So again, that led to depression. And so the benzodiazepine receptors use a neurotransmitter called GABA. It stands for gamma aminobutyric acid. I always just say GABA because that's a mouthful. GABA is an inhibitory messenger. So basically when you send GABA across the synapse, it tells the other synapse not, or the other neuron not to fire, basically. And what happens in these folks is that, you know, it's not working the way it's supposed to. So they're keyed up all the time. So they think that essentially they know in a fear reaction, panic, actual life and death situation, our neurons fire more rapidly. And that's to like get us through the fight or flight, you know, help us process things and get out of there. And then a feedback system is triggered and it helps us to come back down using the parasympathetic nervous system. But what they think happens in anxiety disorders is that essentially that feedback system isn't working. Maybe there's too little GABA in the system. Maybe there are too few receptors. Maybe the receptors that are there are just not working. So we know that the benzodiazepines like Valium, like Xanax work. We know that there are other medications like Buspar that work. But honestly, what's used the most often for anxiety in this day and age is also the SSRIs, because serotonin is also implicated in these same processes. And the great thing is, if they have two, right, depression and anxiety, give them one medication to treat both. The SSRIs also tend to be pretty low dose things, and it's really hard to overdose on them, which is really important if you have someone with suicidal ideation. Some of the old-fashioned antidepressants and also anti-anxiety medications you can overdose on. Some of the examples are Paxil, Lexapro. These are some of the names you may have heard. All right, so we mentioned lobotomy, good old lobotomy. Modern psychosurgery is rarely performed, and they tend to be small lesions that you would make. And again, it tends to be only in really extreme situations. So like really, really severe SCD, or something like we've talked about already, like epilepsy, right? Trying to control seizures. Alrighty, that is a whirlwind tour of psychiatric disorders. And then we will talk about, we're going to focus more on like the learning disorders on Thursday, just because we have a group that's doing ADHD for their presentations. So. I'll hang around. We're like, oh no, we're 1 minute early. I'm right. I'll still hang around for a couple of minutes if anyone has any questions. All right, and Zoom people, have a good day. Thanks for signing on.